Hello everyone. We will specify this video for illustration of sympathomimitics. First of all, what does sympathomimitics mean? In the past video, I told you about the adrenergic receptors. Do you remember them? Alpha 1, Alpha 2, Beta 1, Beta 2, and Beta 3. We have a rule stating that any drug activating these receptors, either all of them or part of them, is termed sympathomimetic. In other words, any drug that has an effect resembling or mimicking the stimulation of the sympathetic system is termed sympathomimetic. Okay, the sympathomimetic family is such a large one. It has so many drugs, which we will study together. Now, how are they classified? They are classified by two methods. The first one is according to their mechanism or mode of action, the way they act. The second method is more of a chemical one. They are classified according to their chemical nature. I'll tell you the advantage of each classification and why are we doing this. According to the mechanism of action, imagine if this is a nerve ending. Adrenergic or sympathetic nerve ending releases norepinephrine. As you already know, this norepinephrine is released to act on alpha and beta receptors. Now the drug which is applied externally is going directly to these receptors. If the drug is stimulating alpha and beta at the first hand, then it's called direct acting sympathomimetic. It acts directly. However, it can act through another indirect method. It may not go to the receptors, but it go to the nerve ending releasing norepinephrine. And this method, it didn't go to the receptors directly. Instead, it went to the norepinephrine, releasing it from the nerve ending. Is there another method? That's possible. You can disable the enzyme you know as MAO. What would happen if you give me MAO inhibitor? This MAO enzyme is disabled, so norepinephrine present in the nerve ending won't get broken down, thus its level is increased, activating the receptors, which will result in sympathetic stimulation. This is according to the mechanism or mode of action by which they work. Again, direct means it works on the receptors. Indirect means it either releases norepinephrine from the nerve ending or disables this MAO enzyme. Now we have finished the first title, direct and indirect sympathomimetics. Then according to the chemical nature, we are going to see the advantage behind this chemical classification, although I told you that we don't care much about chemistry except in the narrowest limits. You know that there is an amino acid called tyrosine. This tyrosine undergoes hydroxylation turning into DOPA, which is then decarboxylated turning into dopamine. Again, this dopamine undergoes hydroxylation turning into noradrenaline, and noradrenaline is methylated turning into adrenaline. This is what you had studied in biochemistry. Now remember that tyrosine structure has a ring like this. We will later call this ring catechol ring. This ring has OH here and OH here. So there are two OH attaching to it. This ring is preserved when tyrosine turns into DOPA, then dopamine. It is kept with all of these compounds. Then all of these compounds, DOPA, dopamine, noradrenaline or adrenaline, they all keep this original tyrosine ring, which we call catechol ring. Then all of these compounds and everything similar, any compound other than these having this ring is called catecholamine. Catecholamine. What about those that doesn't have a ring? If there are drugs stimulating sympathetic system and they don't have this ring, then they are called non-catecholamines. Why are we saying this? When a drug has this catechol ring like these, DOPA, dopamine and so on, this ring, as you can see, has two OH groups, and these two OH groups are water soluble. So they are the one making these drugs water soluble. And you know that anything in order to be absorbed, any drug swallowed orally, in order to be absorbed and reach the circulation, it shouldn't be water soluble. Instead, it should be lipid soluble. So these two OH groups are the reason why these drugs are not absorbed orally. And these two OH groups are also the reason why these drugs can't cross the blood-brain barrier. When we are asked why can't these drugs cross the blood-brain barrier, we say because it contains catechol ring, but truth to be told, it's not the catechol ring, it's the two OH groups, and sometimes there are a third one. They are the ones preventing drugs from being absorbed or crossing the blood-brain barrier. Not only this, but any catecholamine can be broken down by Mansoura, and it's destroyed within minutes, 3 or 4 minutes at the latest. So we are classifying catecholamines sometimes according to chemistry, whether they contain catechol ring and called catecholamine, or doesn't contain catechol ring and called non-catecholamine. Thus, if you say your drug is catecholamine, then take into consideration that it has these 4 qualities. Any catecholamine, any drug containing this ring, is not absorbed orally, can't cross blood-brain barrier, destroyed by Mansoura, doesn't last 4 minutes in your body. But is there a way for these drugs to be absorbed and cross blood-brain barrier and so on? Of course there is a way. Remove these two OH groups that are making these problems. However, when you remove these two OH groups from the structure, it's no longer called catechol ring. So you converted this compound from catecholamine into non-catecholamine. Okay? This was about the classification of sympathomimitics. Now when we study the sympathomimitics, we will pick the drugs in order and discuss them one by one. We will begin with the most important member of the family, which is adrenaline. The most important drug in the family is always called prototype. When you see a large family of drugs and there is one major important drug, it's always called prototype. Then adrenaline, it is the prototype of all sympathomimitics. So we will discuss it in detail, and the rest of drugs will be explained in relation to it. 1 or 2 lines in relation to it. Thus, we will discuss adrenaline in detail. Now, let's talk about this adrenaline. First of all, adrenaline is not the scientific term. The scientific term is epinephrine. Epinephrine. What is its story? Epinephrine is the chemical transmitter that you know present inside sympathetic nervous system. Not only this, but it is the one released from the gland you know as suprarenal medulla, so it's natural in your body. When they discovered it in 1900 or in 1895, they could isolate the epinephrine or extract it from the suprarenal, and they later could synthesize it in labs. When they synthesized it in labs in 1904, the company which chemically synthesized it called it adrenaline. Thus, this adrenaline had become his trade name. Hence, if you want to be scientifically exact, use epinephrine. The trade name is adrenaline, but since it is a very old well-known name, then books are now using these two names interchangeably with each other, so you can see both names in books, they are both correct. Still, the more scientific name is epinephrine, okay? For each drug, especially when it is a prototype and an important one, you will have to talk about a group of headlines, so we don't get confused. The first headline is chemistry of the drug we are talking about. 2. Pharmacokinetics, and we will explain what does kinetics mean soon. 3. The mechanism of action, how does it work in your body. 4. What are its uses, in which diseases you need it. 5. How do you give this drug? In other words, administration. How can you administer this drug orally or by syringes, or in what way? 6. What are the adverse effects that we don't desire? Adverse effects are sometimes called side effects. However, the term adverse effects is better because it means they are undesirable, unlikable effects. 7. The contraindications. Contraindications mean specific situations in which a drug should not be used. 8. If there are certain precautions, warning and recommendations during drug administration so you don't cause problems. What do you think is the safe drug? Safe drug is the drug which the patient hasn't taken yet. Once the patient receives the drug from you or it enters his body, then it has become unsafe. You can't get it out. That's why we are teaching you all of these headlines so you know what you are doing. Now back to adrenaline. Let's begin with its chemistry. First of all, and as I told you before, adrenaline is something natural in your body. Here it's formed in the nerve ending and in the suprarenal gland, thus it's natural, okay? It's natural and its chemical structure contains this ring which I told you about called catechol ring and has two H groups, so it's natural catecholamine in my body. But then do you think that adrenaline present in this bolus is extracted from human? Of course no. It was chemically synthesized by a drug company, and when it was firstly synthesized by this company, it was in the form of crystals, like sugar crystals. The sugar we eat, the pure adrenaline or epinephrine, is originally crystals like sugar crystals. But in order to be administered, it must be dissolved in water. So the company dissolved it in water and released it in small boluses like this. But when the company released it in boluses, they observed something important. They observed that when adrenaline crystals dissolve in water, they don't remain as much for a long time because they are unstable. Unstable means they are rapidly broken or oxidized. They change. So if adrenaline remains in its bolus, or if you draw it but left it in the syringe for a long period, it might be oxidized by the air. Sometimes it's not the air, but it's the light itself. And this process is called photoionization. So that's why sometimes when you draw epinephrine, but keep in mind that when you draw epinephrine by a syringe, its color should be clear like water. This is the sound epinephrine, not the expired. However, sometimes you may see a bolus like this. It's also epinephrine. I'll put them both beside one another and hopefully you can see and spot the difference. Sometimes you see another epinephrine bolus, but its color is darker. If you draw this dark colored bolus by a syringe, its color will be like this, tea color. Where did this color come from? Because this one is expired. Long period had passed, so it's damaged by light, or if it was exposed to air, then it's damaged by oxygen. This brown compound you see is called adrenochrome. This adrenochrome is not adrenaline, adrenochrome. This is toxic. This brown compound is toxic. In other words, when you draw adrenaline by a syringe, if you noticed its color has changed, then don't administer it. This one is expired and it's no longer fused. Okay? The company made epinephrine and dissolved it in the bolus. They made this bolus 1 milli. This is the bolus. They designed it to contain 1 milli, 1 milliliter, and they dissolved it in this 1 milliliter 1 milligram. So it's 1 milligram dissolved in 1 milliliter. This concentration means it is 1 per 1000, because if you dissolve 1 gram in 1 millimeter, gram in milli, then this is 1 to 1. But you dissolved 1 milligram in 1 milliliter. 1 milligram is 1 per 1000 of a gram. So the concentration in this bolus is 1 per 1000. When I tell you that we use epinephrine solution with a concentration of 1 per 1000, it doesn't mean that we dilute this bolus by 1000. We don't dilute it with water. The company is already producing them diluted by 1000. They are ready for use. This bolus is already 1 per 1000 solution. This is about its chemical composition. We said that it's a natural catecholamine, and I told you how it's manufactured and produced. Now let's discuss the second headline, pharmacokinetics. When we say pharmacokinetics, kinetics means the motion of the drug. When you say kinetic, it means the motion of something. What does the motion mean? It means 4 topics, which are absorption, how about its absorption, distribution, how it spreads throughout the body and to which tissue, metabolism, how it gets broken, excretion, from where does it exit and in what form. Now about the absorption. I told you adrenaline has catechol ring. Could it be absorbed orally? Can I make adrenaline pills? The answer is no, because the catechol ring is preventing its absorption. Not only this, it's not only prevented by the catechol ring, but you also have in your intestine Maw-and-Comte enzymes. So even if it didn't contain catechol ring, Maw-and-Comte would destroy it before it reached the circulation. Then its oral absorption is not available. So what about the skin? Can I put adrenaline on my skin? I'll tell you later. It causes vasoconstriction, so its absorption is very minimal, because when it makes vasoconstriction, this area won't have sufficient blood, so its absorption is decreased. But what about the eye? Can we make it eye drops? We used to say that if adrenaline is made into eye drops and instilled in eyes, it wouldn't be absorbed. Why? They said because tears is alkaline and it destroys adrenaline. Later, it was found out this isn't scientifically accurate because adrenaline can be indeed absorbed into the eyes. Not only absorbed, but it may also reach the heart, resulting in systemic effect. But anyway, its absorption into the eyes is little. So it could be absorbed via conjunctival sac in the eye, but its absorption is little. They later made a better form of adrenaline with a better absorption called dipivalile adrenaline. Dipivalile adrenaline. This word, dipivalile, refers to better absorption into the eyes, so it could be available when we need it for the eyes. So, there is no oral absorption? Skin absorption is sluggish, little amount is absorbed due to vasoconstriction? It could be absorbed into the eyes, but it's better to use the other form called dipivalile adrenaline. It can also be taken by breathing. Breathing means by inhalation. We take this bolus, break it and dissolve it in water. Then we add the solution to a device called nebulizer. Nebulizer is a device that vapors the water by ultrasound. The patient can inhale the water vapor containing adrenaline so it can be absorbed by the lungs and act locally there. Now about the second headline, distribution. When I give you adrenaline, it spreads throughout your body. But could I ask you a question? Can it reach the CNS? Can it cross the blood-brain barrier? The answer is no. Why? You know it can't cross the blood-brain barrier because it has catechol ring preventing it from this. Thus, it can spread anywhere but the brain. The brain is forbidden from external adrenaline. But don't allow anyone to trap you. The brain is filled with adrenaline. However, the brain is locally synthesizing this adrenaline. Adrenaline is synthesized within the nerve body. CNS synthesizes adrenaline and uses it as a chemical transmitter. But externally administered adrenaline doesn't reach the brain. Does the brain contain adrenaline? That's certain, from where it's synthesized there. Okay, now the metabolism. I told you that adrenaline is broken down by something called Bowen-Comte within minutes. The bolus you take doesn't last for 2 or 3 minutes in your body. But in what form is it excreted? I told you in a previous video that adrenaline is broken down and converted into 2 compounds. A compound called metanephrine, if you remember. Do you remember metanephrine? The other compound, which is more well known and present in your book, is called valinyl mandelic acid. It is excreted in urine in this form. Do you remember when I told you that when we find high level of epinephrine or its metabolite, it means the patient may have a certain tumor? Do you remember? Which is called phenochromocystoma. This is about pharmacokinetics. But then, a drug that's not absorbed orally, nor it's absorbed from the skin, then I have to use it in the form of boluses. So it's administered by syringes. And when we use this adrenaline syringe, it's better to be administered subcutaneously. Subcutaneous means beneath the skin. Then can it be given by IV route? IV means the vein. Yes, but it's dangerous. We fear this. It's extremely unfavorable unless it's highly indicated. In the case, then you give it by IV. There is a risk to cause a heart problem if given by IV, so it's better to give it subcutaneously or sometimes by intramuscular route in the muscles. We fear this IV route because it could cause a heart problem and it could lead to a type of dangerous arrhythmias called ventricular fibrillation. Now we explained its pharmacokinetics and how can it be administered. The mechanism of action of the epinephrine. I told you that epinephrine is the natural transmitter present in your body and responsible for activation of the sympathetic nervous system. Naturally, it can activate all of these receptors from alpha to beta, all of them by the same degree. It's not biased to any type of receptors, it activates all of them by the same degree. However, its effect on alpha 2 is not apparent. Its effect can be apparent on them all except for alpha 2. For some reasons. First of all is because this alpha 2 is presynaptic. If you remember, presynaptic means it's present in the nerve endings and in the central nervous system. Thus adrenaline don't reach it. The dose of adrenaline we use cannot be sufficient to stimulate alpha 2 receptors which are presynaptic and somehow far away. Even if it reached them, the second reason, even if it reached alpha 2 receptors, what's the function of this alpha 2? Its function in the first place is to decrease the natural noradrenaline release in your body. So when we give external adrenaline, then it should decrease the internal epinephrine, but the external adrenaline covers this effect. That's why we never discuss its effect on alpha 2 receptors. We always explain its effect on alpha 1 and all of betas. but its effect on alpha 2 is not apparent and not clinically significant, nor it's important. Now, when adrenaline stimulates these receptors, do you remember when I told you that when alpha 1 is activated, it activates a second messenger? Do you remember its name? It's called GQ, so it increases a substance called IP3, which increases calcium level. Do you remember this from the last video? And when it stimulates all of these beta, it increases a substance called cyclic AMP, which activates many protein kinases, resulting in diverse range of effects according to the receptor. This is according to the molecular mechanism. So may I ask you about the mechanism of action of adrenaline? Tell me, it stimulates all of the adrenergic receptors alpha 1, alpha 2, beta 1, beta 2, and beta 3. But if I ask you about the molecular mechanism, then you should tell me about these effects on the level of alpha and beta receptors. However, I may ask you about the effects. You told me that it activates these receptors, correct? But what are the manifestations of these effects on the patients? Don't tell me it activates the receptors and stop. You must tell me what will happen to the patient when we activate these receptors. I can easily summarize this and tell you when we administer adrenaline subcutaneously, it can make all of these effects you know from the past video. Think about the sites and functions of alpha and mention them. But we tend to care about the relevant effects, the very prominent ones. When I give you adrenaline bolus, what do I see immediately? So if we think about the heart, needless to say, effects on the heart are the most important effects we have. So if you hold the heart, what would you see? You can see that epinephrine immediately increases the heart rate and increases the force of contraction. Since it increases the heart rate, then it's termed positive chronotropic. Chronotropic means it increases the heart rate. Since it increases the force of contraction, then it's called positive inotropic. That's okay? So instead of explaining the heart rate and contractility, you can just say adrenaline is positive inotropic and positive chronotropic. But what happens if the level is slightly increased? This is bad. It causes arrhythmia. The heart is confused. And if its level is increased further, arrhythmia turns into a dangerous form of arrhythmia called ventricular fibrillation. The heart could stop and the patient could die. If this is an ECG, cardiography of a normal person, it continues like this. For example, if you give epinephrine in a therapeutic dose means the exact required quantity to induce the desired effect, which is like this bolus here. This bolus is called therapeutic dose. This milli is therapeutic, or sometimes we suffice with half of the bolus. If you give this dose, heart rate becomes like this. Do you see this? This is tachycardia, okay? And if its level is slightly increased, this tachycardia starts to be disordered. It becomes disordered tachycardia. But if its level is increased even further, this tachycardia turns into something like this. This zigzag you see is called ventricular fibrillation, and it means the patient could die. That's why I told you before that we fear to give adrenaline by IV route, because in the vein it can reach the heart suddenly before it's broken down here and there. All the quantity reach the heart. Now you can't ensure its effect. Sometimes it suddenly causes ventricular fibrillation, especially if it is an IV overdose. That's why we fear it. This is about the heart. But what do you think of adrenaline effect on blood pressure? Normal blood pressure is 120 for systolic blood pressure and diastolic is 80. It can be elevated up to 140 and up to 90 and still be normal. Allow me to draw your attention here. If this is the systole and this is the diastole, systolic diastolic, if I may ask you, what is the major determinant of systolic blood pressure? Which force controls systolic blood pressure? If you are good in physiology, then you know the major force control on the systole is the cardiac output. But again, what is the major determinant of diastolic blood pressure? Which force controls diastolic blood pressure, which is the low pressure? If you remember it, then you will tell me it's the peripheral resistance. What does peripheral resistance mean? It means your veins. Still, what does this mean? Is it because of vasoconstriction or vasodilatation? This is what controls the peripheral resistance, and I told you before that epinephrine administration stimulates all of the receptors in your body, alpha and beta, and I told you that it increases the cardiac output. Thus, it's reasonable to say systole will grow up because it increases the cardiac output, which is the major determinant of systolic blood pressure. Not only this, but it also causes vasoconstriction in blood vessels. Most of the blood vessels, except for skeletal muscles blood vessels and coronaries, they contain beta 2. Now, cardiac output plus this vasoconstriction both increases the systole, but vasoconstriction is not the major force. Instead, it's the cardiac output because it is the major determinant of systolic blood pressure. Now there is a problem. Because epinephrine is causing vasoconstriction in some of the blood vessels, while it causes vasodilatation in other blood vessels, which is skeletal muscles blood vessels. But does this mean the forces determining the peripheral resistance are somehow equal? No, they are not equal. It's said that this therapeutic dose, this one bolus or half bolus that you administer, affects beta 2 that's present in skeletal muscle more than alpha. So, in the therapeutic dose regarding your arteries, the effect of a therapeutic dose on beta 2 is more prominent than it is on alpha. This leads to more increase in vasodilatation than vasoconstriction, resulting in decreased peripheral resistance with the therapeutic dose. Consequently, diastolic blood pressure goes down like this. So after you administer a bolus or half bolus of adrenaline, you will see this figure. Systole goes up and diastole goes down. So you may find blood pressure has now become 170/60. Do you see what happened? This went up and this went down. However, if you give a very large dose, 2 or 3 boluses, which is more than a therapeutic dose, then beta refuses to play along, arguing that it only responds to the therapeutic dose and no more. So once you go over the therapeutic dose, alpha 1 starts to dominate all over the body, and beta 2 disappears. Not disappears, but hides. Alpha covers it. And now the majority of peripheral resistance is under the control of vasoconstriction with the high dose. This means with high doses, peripheral resistance goes up. So with a high dose, the graph becomes more like this. Systole is increased and also diastole is increased. This occurs with high doses of epinephrine like 2 or 3 boluses. This is its effect on blood pressure. And that's why you shouldn't rush to answer such questions. If you are asked about its effect on blood pressure, don't say increase or decrease. Instead, be organized like this. Tell him it's according to the given dose. Therapeutic dose, which is a bolus or half a bolus, increases systole and decreases diastole. Then illustrate. Large doses more than a therapeutic dose increase both systole and diastole together. Why? Because in this situation, alpha 1 predominates in high doses, leading to generalized vasoconstriction, increasing the peripheral resistance and the diastolic blood pressure. Okay, this is about its effect on blood pressure. So let's see its effect on other systems. Now I can be very brief. Why? Because all of effects present on the table in your book can occur. All effects you know can occur. So let's remember the most common. What do you think of the bronchi? You will tell me, I remember it has beta 2, correct? But what is the function of this beta 2? It causes bronchodilation. It widens the bronchi. If the airway is narrow, beta 2 widens it through bronchodilation. Still, there is something important. If this is a cross-section in the bronchi, I told you beta 2 causes bronchodilation. Here are bronchial glands. These bronchial glands secrete fluid. This is the fluid irritating you and it's called sputum. Bronchial asthma patients always cough excreting sputum from their mouths. These glands have neighboring blood vessels feeding the gland. Which group do these blood vessels belong to? Are they considered skeletal muscles or visceral blood vessels? As long as it's not a skeletal muscle, then it contains alpha, which causes vasoconstriction. So epinephrine causes bronchodilation on the bronchi by beta 2 receptors, while it suffocates these blood vessels. And when these blood vessels are suffocated by vasoconstriction, these glands don't have enough blood supply. Thus, they stop secreting the fluid, decreasing sputum production, and this is very good for asthma patients or patients with acute bronchial episode, the patient who is coughing a lot and is about to have asthma. This effect is very good for them, and this effect is called bronchial decongestion. The word congestion means blockage and decongestion means to remove this blockage. What about its effect on the CNS? What happens when this adrenaline reaches the brain? Watch out! Watch out! Don't let them fool you. It doesn't go, nor it reach, nor it has anything to do with the brain. It flows with the blood indeed, but it doesn't cross the blood-brain barrier, nor it enters brain tissue. It has nothing to do with the brain. Okay? What about its effect on the eye? How does adrenaline affect the eye? Let's draw the eye and see its effect there. This is the iris. Naturally, this is a coronal section. And this is the pupil. Here is the lens. This is suspensory ligament of the lens, and this is ciliary body. On both sides it turns like this. This part is called ciliary body, which holds the lens of the eye. It's covered with columnar epithelium called ciliary epithelium. That's okay? The ciliary epithelium contains beta 2. Do you remember when I told you that it is responsible for aqueous humor secretion during running? Its function is to secrete the aqueous humor, the eye fluid, which fills up spaces in the eye, and if this beta is increased and secretes large quantities of fluid, the pressure inside the eye is increased, and this pressure is called intraocular pressure. If it is increased behind certain limits, it causes a disease called glaucoma. Okay? If the intraocular pressure is increased more than 22 mm mercury, it's called glaucoma or blue water. What if that has to do with adrenaline? First of all, how are you planning to administer adrenaline into the eye? I told you there is an eye drops. Back then I told you they thought it couldn't be absorbed into the eye, but they later found it could be absorbed. Now, when you apply these adrenaline drops into the eye, this is the cornea, and this is the white part called sclera. Here, by the ciliary body, we have blood vessels called ciliary blood vessels. These are the ones responsible for supplying the ciliary epithelium with blood. That's okay? Adrenaline drops, once they enter the eye, they enter from here. And from here they cause ciliary vasoconstriction, because ciliary vessels contain alpha. Don't it have beta? No, because it is not a skeletal muscle. They contain alpha 1 causing vasoconstriction. And when these blood vessels are suffocated, epithelial blood supply is decreased, so it doesn't secrete fluid, thus ocular pressure is decreased. This effect is very useful if the patient has glaucoma. Glaucoma patients with high intraocular pressure can use adrenaline eye drops causing vasoconstriction in the ciliary blood vessels, depriving the ciliary epithelium from blood, so this beta 2 doesn't secrete fluid and ocular pressure is decreased. That's why we invented the eye drops I told you about called dipovilyl adrenaline. Why dipovilyl? To enhance its absorption into the eyes. Anyway, we have more specialized drugs treating glaucoma nowadays. It could be used, it's not wrong. However, when we discuss glaucoma, we will mention more recent and more effective drugs better than this one. But anyway, adrenaline still have a benefit when it comes to red eyes. If someone complains of constantly red eye, and he doesn't like its appearance because it's always congested, then we can give him adrenaline for a better look, as it causes vasoconstriction in these vessels, sclera become clear. So among the advantage of adrenaline is its use in the red eye, so glaucoma and red eye, as it decreases ocular tension and makes the sclera more whitish. This is about its effect on the eye. And you can always predict what happens in the other systems without much effort. For example, if I ask you about the uterus, you would tell me if the woman is pregnant, then her uterus have mainly beta 2, which causes relaxation. What about the hand? You would tell me that skeletal muscles present in my hand contain beta 2, which is responsible for tremors, so it can cause tremors. However, all of these effects are somewhat temporary. As I told you, it's broken down within minutes by Mao and Comte. How does it affect blood sugar? Blood sugar means we are talking about the liver. The liver has something called glycogen, and here is beta 2, which is responsible for liquefying this glycogen, so it increases blood sugar. What about blood potassium? It activates beta 2, and beta 2 moves potassium from blood into tissue, causing hypokalemia. But again, all of these effects are temporary. They won't last long enough to harm the patient, because injection effects don't last for minutes, as I told you. Now we have discussed its effects, all the major effects that happens when we use epinephrine. After this illustration, can you tell me, in what situations do we need this epinephrine? We always begin with pharmacological effects in order to prepare your mind for the following concept, which is uses. Now I have prepared your mind for some of its uses, based on its effects on the body and how it can be administered. Number 1, let me ask you first, before we dwell into details, how long does this bolus last? It's broken down after minutes. Then, could we use it for treating chronic diseases, long-lasting diseases, or can we use it only in emergency? Since it's broken down within minutes, then it's reasonable to use it in emergencies. Among the emergencies which we need adrenaline for, something called acute anaphylactic shock. What does anaphylactic shock mean? You will hear about it very often in pathology and in microbiology and many others. This is a type of hypersensitivity called immediate hypersensitivity, very dangerous type of hypersensitivity called immediate type. For example, some people have penicillin allergy or bee bite allergy and many other allergies. This circle is something called mast cell. Mast cells in your body are storing such a cursed compound called histamine. In some allergic patients, when they receive a penicillin injection, penicillin go and pop this mast cell through a certain mechanism that you will study later in detail. It's not our role now to discuss mechanism of anaphylactic shock. I only need you to know that penicillin pops this mast cell if you are allergic to it. So, histamine is released. This cursed histamine kills you because it causes severe bronchoconstriction and severe vasodilatation. That's why allergic patients receiving a penicillin injection, their faces immediately change. Before you finish your injection, during the injection, that's if he's allergic to it. And by the way, this allergy is not very common. It's only 3 per 10,000, which means among each 10,000 human, there are only 3 who have penicillin allergy. So it's not very common as you may think. If a patient is allergic, his face starts to turn red, his voice changes, and if you continue, he would collapse. He would have a syncope from the severe vasodilatation caused by histamine. In this situation, the only quick and emergent savior is an epinephrine injection. Why do we use epinephrine in this situation? Because it performs 2 effects that oppose the effects caused by histamine. First of all, its effect is very rapid. It immediately saves the patient from this immediate hypersensitivity. Epinephrine causes bronchodilation and vasoconstriction in most of the blood vessels. It reverses the 2 effects caused by histamine. That's why it's called physiological antagonist. Antagonist means the opposite, the physiological opposite of histamine. This situation may have only one treatment, which is a bolus of epinephrine. In this situation, you are in rush. So, can you give it intravenous? No. I'm still insistent on how dangerous it's to give epinephrine through the IV route. So should we give it subcutaneously? This is possible. However, subcutaneous injection might be a bit slow while you are in rush. That's why the best route for epinephrine administration this situation is the intramuscular route. Intramuscular in the muscle. Where exactly? In the lateral thigh muscle. Thus, we meet halfway. You didn't give epinephrine through IV route, exposing the patient to the danger of ventricular fibrillation, nor you gave it subcutaneously, which is slow, so you choose a midway route, so we meet halfway. You may then have an MCQ stating the best route of administration of adrenaline in cases of anaphylactic shock. Immediately pick the intramuscular route in the lateral thigh muscle, okay? So that some companies are now producing adrenaline in the form of auto-injectors. Auto-injector means it's already loaded in a covered sterile syringe, so it can be readily available in schools or other places at which people may experience this form of allergy due to some food or bites or whatever. We don't have time to call an ambulance which may come after 3 hours, another 10 hours to deliver the boy to the hospital, who may not survive for another quarter or half an hour. So they are now producing pre-loaded epinephrine, thus it can be readily available for use. If a problem occurs, you can use this epinephrine immediately in the lateral thigh muscle, saving the life of the patient as if something never happened. Okay? This is its first use. The second use of epinephrine, people who experience something called acute bronchospasm. From its name you can predict its nature. A young child with a common cold. If this is the larynx, like this, our larynx has a relatively wide lumen. So when we cough a lot, even if some inflammation and edema occurs and the wall becomes swollen, the airway is still sufficient. It's not dangerously narrowed. However, in children, the larynx or the airways is naturally narrow. So when the child have a common cold and remain coughing for the whole night, this continuous cough could lead to inflammation in the wall of the bronchopulmonary tree, especially in the larynx, which is already narrow. Its lumen is already very narrow. Once edema occurs, do you know what does edema mean? It means vasodilation as a result of this inflammation, and this vasodilation starts to leak water. This widened blood vessels start to leak water. This water causes edema, so the airway swells, and this swelling results in even narrower airways. The child can no longer breathe. So he's brought to your clinic with a bluish face from a respiratory distress that can kill him. This is emergency. The immediate management is to give an adrenaline bolus, subcutaneous or intramuscular. Sometimes it's given by inhalation. In this situation, we sometimes empty the bolus on half cup of water in the device I told you about called nebulizer, and through the mask, child inhales the vapor containing epinephrine. And what does the epinephrine do? The epinephrine immediately dilates his bronchi. Not only this, but it also suffocates these blood vessels responsible for the edema. When they are suffocated, edema is decreased, and when edema is decreased, the wall returns to normal and the air passes effortlessly, and the episode goes away. Of course, we won't allow this boy to live like this. Instead, we prescribe him some regular medication to prevent this episode from occurring again and instruct the mother on the management of this episode. We tell her about more specialized medications, like those specifically acting on beta-2. An inhaler, for example. This inhaler acts on beta-2. It's not reasonable to let her come from time to time to the hospital for saving her child by adrenaline. So we tell her this inhaler is a beta-2 agonist or stimulant. If this episode occurs once again, you can use this beta-2 inhaler, hoping for some bronchodilation, improving the condition. However, the epinephrine is still more efficient. Don't forget, epinephrine doesn't only cause bronchodilation, it also causes vasoconstriction in the blood vessels responsible for edema and swollen walls, which is the origin of the problem. This is the second case. The third case is the cardiac arrest. Cardiac arrest comes in various types. A fresh medical student thinks of cardiac arrest as a general word, but in reality, cardiac arrest has so many types. At least you know that cardiac arrest means ineffective pulsation. If you try to feel the pulse, you don't feel it. Either the heart stops completely, flat line like this one, nothing to see, just flat line, or this cardiac arrest can be ventricular fibrillation, zigzag lines like this one on the cardiograph. Sometimes you might see actual cardiograph like this. It means there is electricity. Electricity is present but no pulsation, and so on. So for now, cardiac arrest means ineffective pulsation for many reasons, but they are not our concern. Generally, when the heart had a problem and we couldn't feel the pulse, we used to give the adrenaline injection intracardiac. We used to load 1 or 2 or 3 boluses of epinephrine. Then we replace this needle with a larger one like that of cannula or cannula trocar. And we give it intracardiac, hoping for stimulating the heart. As you already know, the heart has beta-1, so you can wake the heart up. This is called resuscitation. Waken the heart up. But then they said, this is not right. This process is not correct. The process of injecting adrenaline intracardiac in the cardiac arrest cases, hoping for waking the heart up, is not right. Why not right? They said cardiac arrest cases, when the heart stops beating and the circulation becomes stagnant, there is an immediate release of vasodilator mediators. Thus you can find out that the circulation of the collapsed patient with a stopped heart is dilated. That's why If this person dies, the forensic pathologist writes down well-known phrase you all know from the news when they say that the cause of death is extreme drop in the blood circulation and sudden stop of the heart muscle. Sudden stop of the heart, okay, the heart stopped. And blood circulation means there was a vasodilatation leading to circulatory failure because there was a release of vasodilator metabolites which caused a state of generalized vasodilatation. That's why they see no benefit of waking the heart up by adrenaline, given adrenaline injection to wake the heart up. But then when the heart wakes up and starts pumping, if there is a generalized vasodilatation, then all of this process is useless. Or as they say, you went on a wild goose chase because the heart starts pumping and very weakly while the circulation is still dilated. So the purpose is not to give adrenaline intracardiac. We don't aim to wake up the heart. Instead, we have a higher purpose, more important one, which is to cause vasoconstriction firstly in the collapsed circulation. Give a drug causing vasoconstriction in this collapsed circulation, fix it first. Then you can later perform something called CPR, cardiopulmonary resuscitation, compressing the chest wall in regular pattern and so on. When you do this compression with your hands, this compression that you do with your hands, if there is a vasoconstriction in the circulation, if you give a drug causing vasoconstriction in the circulation, then by this hand compression, the ventricle pumps a little amount of blood to the brain because you close the peripheral circulation. However, if the circulation is patent under the effect of vasodilatation, then as long as you perform CPR, all the blood that's being pumped will be swallowed by this patent circulation. This is why new recommendations say that if you want to use epinephrine, no problem, but give it by IV, not intracardiac. Why? Because IV means it runs in the circulation, causing vasoconstriction. This is what I aim for. And naturally, it will reach the heart, ultimately stimulating beta-1. However, this is not the purpose. The first aim is this vasoconstriction. This is why some people say, since our purpose is to perform vasoconstriction CPR, then can we replace this epinephrine with another vasoconstrictor drug? Indeed we can. Yes, you can give another vasoconstrictor drug while you perform CPR manually, and don't be afraid, it will work. So the purpose in this situation is not only to stimulate beta-1, no, the purpose is to cause vasoconstriction. We sometimes ask students during oral exams, why are we using adrenaline or epinephrine in cases of cardiac arrest? They immediately answer, it's to stimulate beta-1. This is not wrong, however, it's not the purpose. Our purpose is to cause vasoconstriction in this collapsed circulation, so when we perform CPR, the heart doesn't confront all of the circulation. Thus, these little contractions can deliver the blood directly to the brain without being lost in the circulation. I hope I made this clear for you. The fourth use of adrenaline, do you notice that these are all emergencies? Do you notice that all of its uses are for emergencies? All of these are emergent situations when we need to act very rapidly. However, this fourth use is not an emergency. Our colleague dentists know very well that dental anesthesia contain vasoconstrictor compounds. But why? Why do they sometimes add epinephrine to dental anesthesia? Dental anesthesia requires a form of anesthesia called local anesthesia. If local anesthetic is used alone, let's assume that this is a tissue. Local anesthesia duration is short. It doesn't last long in the tissue because it is washed by the local blood vessels. When you inject this local anesthesia alone, it's washed by the blood vessels. For example, how can your dentist perform a lengthy procedure, say for 1 hour, while the local anesthesia lasts only about 15 minutes? That's why companies are now adding adrenaline to the local anesthetics, so it produces vasoconstriction in the blood vessels. And when these vessels become suffocated, we acquire two merits. The first one is decreased bleeding, so the dentist can have a better working field while he is extracting a tooth or whatever. The bleeding is decreased. Number two, local anesthetic can act now for longer duration. Instead of lasting for 15 minutes, it could now last for half or 2 hours, according to the use concentration. So that some people thought about replacing this epinephrine with another vasoconstrictor drugs, and that's okay as long as it produces vasoconstriction. For example, here we have an anesthetic cartridge. This is anesthesia you receive when you are at the dentist. He put this one in the injector and gives it to you. This cartridge comes in two types, one with red written over it, like this one. If you can see it, this red means this anesthesia without a vasoconstrictor. It doesn't contain adrenaline. If you use this one, it can last for maximum of 30 minutes. However, there's another one that looks exactly the same. I don't have it now. It's the same as this one except for green written over it. So the green cartridge contains adrenaline to produce vasoconstriction or something like adrenaline. So if you want to get local anesthesia from the pharmacy, he would ask you whether you want it red or green. Red ones means it doesn't contain adrenaline nor any vasoconstrictor. The green one contains a vasoconstrictor. Now you know the difference between both samples in case you see them during clinical exam. Now if someone asks you, why do we add epinephrine to local anesthesia? Tell him we do this for two reasons. The first one is to decrease the bleeding. The second reason is to prolong the duration of the local anesthetic. Sometimes patients go to the dentist. An elder man, about 60 or 65, went to his dentist for some procedure. So the dentist gave him the local anesthesia containing adrenaline. He was expecting this anesthetic to last for an hour or two. Instead, he was surprised when the patient told him he feels immense pain after only 15 minutes and he asks for another anesthesia. The dentist gave him another one, but it didn't help. This anesthesia only lasts for 10 or 15 minutes. Of course, you are now surprised exactly like the dentist. Why didn't the anesthesia last for long? Why didn't the adrenaline produce vasoconstriction lengthening the duration of this anesthesia? You would keep wondering about this, asking the patient for his medical history, and you may then find out this patient has enlarged prostate. For example, this will be explained soon. And this prostate, now called benign prostatic hyperplasia, a common disorder among older men about 50 or 55 years old, and its treatment is alpha blocker. In order to avoid urine retention, we treat this condition with alpha blocker. I gave you an idea about this concept during the introduction. Now look what happened. This patient is a male aged 55 years old, and it happens that he has benign prostatic hyperplasia and receiving alpha blocker. The urologist gave him alpha blocker in order to avoid urine retention. When he went to the dentist and received the anesthetic containing adrenaline, now adrenaline can't produce vasoconstriction because this alpha receptor is already blocked by alpha blocker, and this is the reason why the anesthesia didn't last for long. Thus, if you have a smart, clever dentist, he will always be prepared for this scenario. Elder men above the age of 50 or 55 years, before they make any procedure, they are asked by their dentists whether they have any prostatic problem and taken any drugs for the prostate. If he confessed to have an enlarged prostate and receiving pills for this condition, the phrase receiving pills for this condition means they are most probably alpha blockers. Accordingly, the dentist should be prepared for this situation and he may ask him to skip these tablets on the days he is coming to the clinic, and so on. I have illustrated the uses of epinephrine for you. So now let's revise a little. How do you administer adrenaline? Don't ever say oral. It comes in boluses. These boluses are given either by subcutaneous or intramuscular injection, and the intravenous only in one situation. Do you remember it? The only situation you are allowed to give intravenous adrenaline is the cardiac arrest. Except for this one, we are afraid that it causes ventricular fibrillation and kills the patient itself. Now, can you expect the problem caused by this adrenaline? The problems we expect, which is known as adverse effects. Adverse effects are the side effects. Number 1. When a patient receives subcutaneous epinephrine, his blood pressure may be markedly increased. This may be unexpected and it may turn into cerebral hemorrhage, bleeding in the brain. Number 2. Adrenaline can cause some tremors, but this is not significant effect. After all, these tremors subside soon. Number 3. Adrenaline could sometimes stimulate the heart excessively through its beta effect, causing tachycardia, which may turn into arrhythmia or even ventricular fibrillation. Cardiograph would be messed up like this. Goodbye. He was kind. May he rest in peace. Number 4. Epinephrine could stimulate the heart excessively while the heart is already weakened by a cardiovascular disease, like heart failure or whatever, which leads to acute heart failure. Acute drop in the heart functions, the patient collapses, can no longer breathe, and ends in ICU. 5. Epinephrine can lead to a condition known as acute pulmonary edema. Pulmonary edema means water within the lungs. From where does this water come? You know, this is the heart and this is the lung. And you know the lung receives the pulmonary artery from the right ventricle, then the lung sends the blood to the left atrium, then the left ventricle, and then it goes to the aorta. That's okay. Now when a patient receives adrenaline, it increases heart's contractility, so blood is flowing in high pressure through the pulmonary artery. It arrives to the lung in high pressure, thus the intrapulmonary hydrostatic pressure is increased. Then the lung tries to get rid of this blood from the other side, but it needs a systemic vasoconstriction, as it causes vasoconstriction in the systemic circulation, which means that it increases the contractility while it blocks the way. Who is the one trapped in the middle? It is the lung. It receives high blood pressure flow and cannot get rid of it due to vasoconstriction. That's why it leaks water. The capillaries in the alveoli don't stand this elevated pressure and starts to ooze a fluid. The alveoli are filled with fluid, and the patient suffers now from acute pulmonary edema or water in the lung. What do you think is the most dangerous among these? Not only these, there is still one more. You can give too much adrenaline. For example, a plastic surgeon working on the little finger, when he chose the type of anesthesia, he picked a local anesthetic with epinephrine, which causes vasoconstriction, but he gave too much and he repeated the injections, injection after injection. The procedure is taking time and he is still giving these injections containing vasoconstrictor. This vasoconstrictor could suffocate the blood vessels, especially those on the tip, because they are very sensitive, so that this suffocation could kill these tissue, causing something known as gangrene. Gangrene of fingers. The fingers would turn very cold, their color is changed, the next day they lose its sense, and now they must be amputated. They are not viable. What do you think is the most dangerous among these? They are all dangerous, as epinephrine is a life-saving drug during emergencies and it does save lives of many patients. However, this drug can cause major problems itself, and I think that the most dangerous one among all of these effects is this one, ventricular fibrillation, because this is a dead patient. Fibrillation means unless there's an emergent ICU admission, the patient dies. On the other hand, cerebral hemorrhage is indeed very dangerous. No one can deny brain bleeding is dangerous. However, cerebral hemorrhage could be localized and the patient could still live. He may live with a deformity, but at least he lives. The others are very debatable. For example, tremors, it's nothing. Acute heart failure, he would still live. Some water in the lung, he would also still live. Fingers gangrene, they would be amputated. Of course, it's a disaster, but he still lives. On the contrary, this one with ventricular fibrillation, he dies. So when you have an MCQ stating the most dangerous side effect of epinephrine injection is, pick this one, arrhythmia and ventricular fibrillation. Arrhythmia alone is not sufficient. Now, let's shift to the next headline, which is contraindications. Contraindications means when not to use. Of course, you are smart enough to know that the term contraindications, contra means the opposite of, and indications means when to use. So contraindications is when not to use. You know that adrenaline causes all of these previous misfortunes, so it is reasonable not to use it in cases of hypertension. Don't give someone with high blood pressure adrenaline because it causes hypertension itself. Don't ever give adrenaline to someone complaining of cardiovascular problem, someone with angina, ischemic heart disease, or so on, as it increases the cardiac work, which increases the anginal pain. His chest could become painful and he may encounter an acute heart attack, so don't. Number 3, don't give adrenaline in large dose with local anesthetics. I always tell my dentist to be careful with the amount of local anesthesia because I may need another during the procedure, so he wouldn't give me 5 cartridges one after the other and they contain epinephrine, because this prolonged vasoconstriction could lead to tissue necrosis, so it's contraindicated to give an overdose of the local anesthetic containing epinephrine. Among the most important cases is a group of cases called cardiac outflow obstruction. What's a cardiac outflow obstruction? They are a group of cases which are collectively known as cardiac outflow obstruction. Look here, this is the heart, and this is the pulmonary artery going to the lung, and this is the aorta for systemic circulation. Any disease that hinders the flow of blood in the pulmonary artery or the flow in the aorta is called cardiac outflow obstruction. This case is considered one of this large topic. For example, but let's firstly draw the aorta. This is the aorta going out of the left ventricle. Here it is. Let's even draw it with a red pen. This is the aorta and this is the arch. Here is the aortic valve. If there was an aortic stenosis and the aortic valve was narrowed, this would be classified as cardiac outflow obstruction. Or imagine if this was pulmonary artery going to the lung and here was an embolus in the pulmonary artery, something obstructing the flow. It's classified as cardiac outflow obstruction. There is a very well-known cases you will hear about very often during this curriculum, 3 or 4 times. A case known as hypertrophic obstructive cardiomyopathy. Hypertrophic obstructive cardiomyopathy. It was previously called idiopathic hypertrophic subaortic stenosis. It is the same condition. What is this condition? You already know the thickness of the ventricular septum in normal individuals doesn't cross 12 mm or 1.2 cm. This is the ordinary. When you perform a cardiac echo, ultrasonic waves on the heart, the septum thickness shouldn't cross this limit. There are 1 per 1,000. One from each 1,000 individuals is born with a genetic problem. Thickness of the septum is increasing with time and even cross 1.7 cm or 17 millis. It could cross these numbers. Now, when the septum hypertrophies like this and its thickness is increased, know that the heart hypertrophies more on the left side or the left ventricle, while the aorta opens in the left ventricle like this. Thus, the thicker the septum is, the narrower this opening becomes and blood can't flow smoothly from the aorta. That's why it's called hypertrophic, which means enlargement, obstructive, which means hindering the flow. Cardiomyopathy refers to the enlargement, okay? Now, as this child keeps growing up, his problem also keeps increasing. Allow me to draw your attention to this part. I like to give this case all the possible attention because you will see it very often, so I don't want to repeat it again. This child, during his childhood when he was 9 or 10, when he runs or plays football, he doesn't stand there running. As soon as he runs a little, he feels sweaty and slumps or collapse. That's why his friends take advantage of him and place him as a goalkeeper because he can't run. He later goes to his mom, cries, complaining of not being able to match his friends. Later, when his mom takes him to the doctor, complaining her child can't exert normal effort and becomes bluish as he tries, the cardiologist asks her to perform a sonic wave on the heart, or what's known as echo. When the cardiologist receives the report of cardiac echography, he observes the child has a thickened intraventricular septum, more than 1.5 cm or 15 millimeters. This causes narrowing in the outlet of blood flow. Thus, when this child runs or plays football and experiences tachycardia, blood can't get out because the flow is hindered by the septum. And this is the reason why this child feels drowsy. This enlargement is increased with age. As long as he grows up until he is 18 or 20, when it reaches its maximum value. That's why you will hear very often about some people, youth, aged 20 or 22, dying while they are playing football despite having a good general health. You'd even be astonished how could such a healthy guy dies while playing football. Do you know what's the most common cause of sudden death in young athletes, healthy young athletes? It is a condition called hypertrophic obstructive cardiomyopathy. He had this condition and it was not diagnosed before. The symptom kept increasing until it reached a critical level that blood could no longer flow from the aorta. And this condition becomes prominent when he plays football or exercises because the heart is not able to pump all of the blood out. After I have explained this condition for you, do you know why I told you all of this large intro? So you know why this one should never receive adrenaline. Why is that? What would adrenaline do? It causes tachycardia, correct? And increases the force of contraction. And since the septum is thickened, suffocating the aorta, then how can the blood get out, especially with this tachycardia? Then blood can't get out. That's why adrenaline injection could kill this boy with hypertrophic obstructive cardiomyopathy. Last one of the contraindication is thyroid patients. Patients with hyperthyroidism. I'll be brief while explaining this one because it makes much sense. Thyroid patients who have hyperthyroidism, they have lots of T4 and lots of T3. When thyroxine is increased, it makes some changes to your body. Number 1. Thyroxine increases the number of beta receptors. The number of beta receptors in your body and also their sensitivity are increased by thyroxine. Thyroxine is considered as adrenaline cousin. They have the same origin in chemistry. They both originate from single amino acid called tyrosine. Thyroxine goes to your beta receptors in your body, strengthening them, increasing both their numbers and sensitivity. That's why hyperthyroidism patients always complain of symptoms related to beta receptors. They come to you complaining of shaky hands. Why is it shaky? Due to tremors. Why tremors? Because beta 2. They may complain of irregular heart rate beats, insomnia, dizziness, irregular pulse and tachycardia. Why? Because beta 1 in the heart are confused by this thyroxine, which increases their number and their sensitivity. This is what we call sympathetic overactivity. So, patients with hyperthyroidism have sympathetic overactivity due to upregulation caused by thyroxine. Upregulation means it increases both the number and the sensitivity of beta receptors. Thus, it's very reasonable not to give him adrenaline. His beta receptors are already on fire. Thyroxine is already wiping them. So when you give him adrenaline, you are aggravating all of his symptoms. Add to this the second reason. You already know about the enzyme called COMT. I told you once about it. Patients with hyperthyroidism have low levels of COMT by nature. Their COMT is inhibited, so when you use adrenaline bolus, it won't be easily metabolized. That's why his level is increased, causing problems. Now the 5 contraindications of epinephrine. I told you about the 5 contraindications. Not for cardiac patients, not for hypertensive patients. Please don't use epinephrine in high concentration during anesthesia so you don't cause tissue necrosis or finger gangrene. Please don't give adrenaline to this child who has idiopathic hypertrophic subaortic stenosis as he has cardiac outflow obstruction. And please don't give adrenaline to patients with hyperthyroidism. For your information, those 5 patients I mentioned during explaining the contraindication, can you imagine how are we going to treat them? Their treatment is to block these receptors, not to stimulate them with epinephrine. Most of these patients I mentioned are treated with something called beta blocker. You will see that beta blocker are used for hypertension, used for many types of heart diseases, and used for this child. This child with hypertrophic obstructive cardiomyopathy. Cardiologists give him beta blocker so he wouldn't develop tachycardia. And you will see that beta blocker are also used as treatment for hyperthyroidism. Diseases in which adrenaline is contraindicated are always treated with a blocker, not an agonist. I hope to see you in the next video. After we explained adrenaline in detail, we are going to discuss the rest of the drugs, but not in detail like this one.